The reference came for a 56-year-old diabetic patient, stating the patient is having diabetic nephropathy and the proteinuria is approximately 8 gram or 8000 milligram he is excreting. So what next? The topic of discussion is related to that: diabetic nephropathy, when to suspect non-diabetic kidney disease, or when to plan biopsy. What are the features which suggest it might not be a diabetic nephropathy? That is the topic of discussion for today. If we see diabetic nephropathy, there is a natural history is there. Uncontrolled diabetes or diabetes with a duration more than 10 years. Retinopathy usually presents in 90% of the patient. It passes through a particular stages: microalbuminuria, macroalbuminuria, renal derangement. It's a short outline. So whenever a patient presents with very massive proteinuria, more than 5 gram or more than 8 gram for that matter, all of a sudden, this is atypical of diabetic nephropathy. Unlikely some other disease might be there, like membranous nephropathy is more common. Cause of nephrotic syndrome have to be looked for. Up to 3 gram, 4 gram is fine in diabetic nephropathy, that also in later stages. All of a sudden presenting with massive proteinuria is very rare. It could be non-diabetic kidney disease. A biopsy is warranted. First, we have discussed. Second, when the patient presents with gross hematuria or presence of RBC cast. Basically what we are saying is the patient is passing blood in the urine. If it is, and that if found to be glomerular origin based on the RBC cast, that might indicate non-diabetic kidney disease, on condition that it is not a Foley's injury, patient is not the old age, cystitis, that should be ruled out. I hope the residents who are seeing understanding the subject in that context. Age 40-60, if there is no cause of lower urinary tract bleed and the patient is presenting with gross hematuria because of the kidney per se itself, very unlikely it might be diabetic nephropathy. Okay, second is done. Third, absence of diabetic retinopathy. Usually after 5 to 10 years, whenever the kidneys are involved, high chances the retina might have been involved. So if patient is not having retinopathy but presenting with proteinuria and worsening kidney function, that might indicate some other disease rather than diabetic nephropathy. It might be in the background, the diabetic nephropathy, but the main disease might be something else. A biopsy might be warranted. And diabetic nephropathy depends on the person who have seen also. A PG first year from Aftal might not able to pick it. So that is why a good assessment for fundus might be required before concluding or came to this decision. Presence of proteinuria a significant level but there is no retinopathy indicates something is not in the usual history. Probably some other disease might be associated. Take into consideration the age factor and make your DD. The fourth one, rapid onset. The patient have clear past history of well-controlled diabetes. Microalbuminuria is not there. All of a sudden presenting with macroalbuminuria, renal derangement. The sudden onset is bit atypical of diabetic nephropathy. You have to think of some other disease. And the last one, severe renal dysfunction. Urea rising rapidly, creatinine rising from 2, 3, 4, 6, rising rapidly, unlikely in diabetic nephropathy. Some other condition might be there. Some other condition might be glomerular condition or UTI or rapidly progressive glomerulonephritis. Some other condition might be there. You have to be vigilant enough. These are all the conditions where a biopsy might be required, or as per the DD you have to form the investigation. It might not be diabetic nephropathy per se. So that is why knowing the natural history of diabetic nephropathy, the 5 stages of diabetic nephropathy, how it presents is very important, and these are all the atypical situation where you have to plan for biopsy or investigations like anti-PLA2R for membranous nephropathy if 50 years plus nephrotic syndrome, C3C4 level if required, serum protein electrophoresis, serum immunofixation. These kind of light chain related disease examination might be required. One common question, sir, if not diabetic more than 50 years, what could be the cause of proteinuria massive? More likely it might be primary membranous nephropathy. Very common. Amyloidosis is there, even though rare, but as a nephrology per se, more diseases are being referred to nephrology department. Amyloidosis, deposition disease, light chain or heavy chain deposition disease. In that spectrum only, multiple myeloma comes. So these are some of the possibilities on the actual primary disease side, or another one is a simple UTI worsening, causes worsening of KFT, a complicated UTI, because diabetic patients are prone for UTI. UTI can cause this worsening, acute worsening. So next time be vigilant whenever these kind of features are there. Better to evaluate for further conditions so that you will catch the condition early and start the treatment early. Bye bye. In the next video, we'll see regarding another topic.